Okay, there we go. So again, I'm going to be talking about harnessing the host response for infectious diseases. And basically, I'm a clinical infectious diseases physician and a medical microbiologist in the United States at Duke University. I work globally and have for my entire career. This began when I was at the Centers for Disease Control, but my interest is in building up diagnostic capacity in less resourced areas than the United States. I do want to mention that I have some disclosures. I work with a lot of industry partners, and because we do a lot of research. And I also am the chief medical officer for a company that is working with some of the patents that our program generated related to what I'm going to be talking about today. And that's a company called Biomeme. And you'll see when I talk about that element, I just want you to bear in mind that I do work for or have financial interests in that company as well. I always like to give credit to my team very early in my talk, so I'm not just tacking it on at the end. And we have the type of work we do is multidisciplinary. It brings together clinicians, laboratorians. We work with machine learning, statistical analysts, and complex data managers, all part of what we've been doing. We've been doing AI before it was cool, or at least machine learning before it was. So we have a talented team. You'll also see that I've got KDU listed as a collaborator on here. Dr. Darshan De Silva is a PhD immunologist here, working with Dr. Hamali, closely with Dr. Hamali as well. And we've done a significant amount of work in this same area, although I'm not going to be specifically presenting those data today. But we work broadly across the globe and throughout the United States. And I'm going to give you that story of what our laboratory has done over the last couple of decades. And the reason, I'm an infectious disease clinician, and in the United States, infectious diseases are at the top of the reasons for people to be admitted to the hospital and to contribute to prolonged hospitalizations. And that can fall under a sepsis diagnosis when someone comes into the hospital. It may be a pneumonia, maybe pneumonia with sepsis. It may be skin and soft tissue infections, increasingly complications of joint replacements, or a very growing immunosuppressed population related to transplants. And this is, again, very, heavily influences our populations in the United States. Now, if you look at a similar burden here in Sri Lanka, of course, that is probably even a greater percentage of your admissions, at least with my colleagues I work with down at the teaching hospital, Karapkia. The infectious diseases are a tremendous contributing element to the cost and number of infections. And we have a limited number, or our armamentarium, our number or type of diagnostics is what I've always been trying to improve. And we make a lot of assumptions about diagnosis for infectious diseases. In the United States, that actually leads to a large amount of legal issues for clinicians. The United States, I know there is a fair amount of a legal, kind of a suing culture in Sri Lanka. Not nearly as much, though, as there is in the United States. There's a lot of medico-legal costs that are imposed upon the system in the United States. And so better diagnostics will, of course, help us reduce the frequency of those issues and ideally save money. One of the areas that we've significantly focused on is acute respiratory infections. These make up the leading percentage of admissions, as I highlighted before. And most of presentations, both in the inpatient and outpatient setting, and this is the same here in Sri Lanka, at least with our work down in Gaul, the majority of those are presenting with viral infections, but you still end up with a tremendous overuse of antibiotics or inappropriate use of antibiotics. And while this certainly helps save a certain percentage of lives, it's driving the slow pandemic of antimicrobial resistance that's taking over the world. Just in the time that I've been working here in Sri Lanka, and I failed to mention, I first came to Sri Lanka in 2005 after the tsunami, and I've been working with collaborators ever since. And this is probably my 20th trip to Sri Lanka, so I'm very grateful to have the opportunity to have had that be so much a part of my career. But this issue of overuse of antibiotics, I've watched happen during that time. Carbapenem use is now standard for just about anyone coming into the hospital for acute pyelonephritis, acute pneumonia. I've seen it in practice in THK. I'm going to guess it's the exact same up here as well with the frequency of carbapenem use. And that's driving this tremendous outbreak or pandemic of carbapenem resistance that also in Nepal at the time had a very unique expression that you could see on this, what we call a heat map of gene expression. And we didn't have the tools at the time, the data analytic tools, the statistical tools, to generate the type of what we'll call signatures or new diagnostics that we've subsequently been able to go on and develop. But this gave us that proof of principle for the idea to move forward, and really was the basis on which we developed a lot of our program. So the general idea is we take a group of individuals presenting with a certain common presentation. It's fever, it's deterioration in the ICU, it's post-surgical infectious complication. There's some use case we're interested in, and you collect a certain number of individuals with that condition and a certain number of individuals who don't have that condition, and that's the kind of the group that we are interested in generating data from. And what we do is we collect blood, and oftentimes in those tubes I mentioned before, where we collect the whole blood in a PAX gene tube, and we generate different analytes, and it may be metabolites, it may be protein expression, but most of what we rely on, because we find it to be the most robust, are transcriptional or mRNA expression. Then we get to our data management component, and you set up special ways to handle those data, get them aligned and normalized across individuals, and then you put them through the algorithms or the machine learning algorithms to generate what ultimately is a signature or a classifier that says, this is what an individual with that particular condition has, and this is what it looks like when they don't have it. And we give it a probability. So that probability may be at 10% or it may be at 90%. I'll show you some examples of how this looks. And again, we've worked across a variety of different infections and have probably 150 publications in this general area over the last 15 years or so. So our earliest project was with the working with our military, and I know you're a military hospital here at KDU, we worked with our own Department of Defense, who were very interested in developing a new diagnostic that you could test individuals who were getting ready to be deployed. This was in the 2005, 6, 7 time frame when a lot of the United States military was being deployed into the Middle East for various actions. And their interest was, okay, can you do a test on people who are about to go off in a submarine or about to be deployed on a ship? And can you say who is going to become sick or who may be incubating an infection, particularly a respiratory tract infection, so that we can pull them out, quarantine them, and protect the others when it's something we may not know about? So a pre-symptomatic diagnostic. That was the idea that they were most interested in. Well, developing that type of a diagnostic means you've got to capture people at the point when you know they've been exposed to an infection, but they're not yet symptomatic. So the best way we came up with doing that was using what's called a controlled human infection model. So by that, we actually take individuals, and just like you would do with a group of mice in the laboratory, you can give them an infection at a particular time. Everyone gets infected at the same time, and you keep them in a quarantine unit. They're all being compensated, and this is all approved by our ethical IRBs and et cetera, or our reviews. But they're kept in quarantine for a 7 to 10 day period, and you collect frequent samples during that time, and you know the period when they are not symptomatic and the time period at which they become symptomatic. So it's a very good model for understanding when someone is going to become infected. It's about the only way to really do this, although at the time it kind of felt a little uncomfortable with my Hippocratic oath, where I'm really not supposed to be making people sick. But again, we worked very closely with our ethical review teams to be able to do this. And so at the end of the time, what we did is we captured, we gave them the infection, caught their blood throughout the time. We generated data from their extracted mRNA, put it on what are called Affymetric arrays. These were now much more commercialized arrays for the assessment of the immune response. And we demonstrated that 36 to 48 hours after inoculation, you could easily detect those individuals who were having an innate immune response to the infection. But this was usually before they developed symptoms and before they developed high viral loads for detection. So you were actually in that period of time before they were developing infection. And we ended up doing this so successfully that we kept working with the DoD and then ended up working with the United States National, the NIH, National Institutes of Health. And we've probably worked with over 300 individuals over the course of the last 10 to 15 years across a number of different viruses, different strains of influenza, different strains of human rhinovirus. We've done studies with RSV as well. Initially, we were doing these studies with our colleagues in the UK. Now we're doing these studies in the United States in our facilities at Duke University as well. So this has been developed over a long period of time, but what we have confirmed and continued to refine is these signatures for both time of infection as well as early infection. But the question is, does the data we're generating in these controlled human infection models look the same as what happens in real life? So how are we going to capture individuals in real life who are about to become sick. So what we ended up deciding to do is we worked with our population there at Duke University. We worked with freshman students. So these are first-year students coming in. They're about 18 to 19 years old. They are going into dorm facilities. They live together. They share the same environment, much in the same way that new recruits share barracks and share the same environment that way. It's our version of the barracks, is the university dormitory system. And what we did is called an index cluster study. So we would monitor about 500 students. They would electronically enter whether or not they had any symptoms during that day. We'd capture that information. When we got a number of students, or at least one individual who said they were sick, we'd go in, collect samples from those who are their close contacts, and do that over a series of days. So this is our same, it's like the controlled human infection model, but we did it in a kind of a captive dormitory environment. Not so captive because they were out and about and mixing. But over time, and we did this for several years, we collected serial collections on enough individuals who became sick across a number of different viruses that we could actually continue to refine, but more or less we confirmed that the data that we had generated before, where we had these interferon-based viral signatures, worked well in this particular population as well on the college. So we validated it in a free-living population. Now, one question was, is that information actionable? Can you do something about it? Does it help to say this person is going to get sick? Well, what we did was one kind of interesting study design using that controlled human infection model. And for that, what we did is, for a subset of the individuals in the study, we gave early antivirals, in this case oseltamivir as shown in the figures, and we demonstrated that if you gave early oseltamivir, you could reduce the symptom burden, you could reduce the viral burden, and you could actually demonstrate that there was a reduction in the strength of that innate immune signature response as well. So you now have the ability to diagnose the patient. You know what their signature looks like at the time they're sick. You've pushed it back in time, so you've shown that it's present even before they become sick. You've shown that there's a public health intervention that you can put in place to treat early that will help reduce symptoms and reduce the virological burden, so thereby reducing the likelihood they spread the virus. You just need to now make a diagnostic that people are interested in. Well, about the same time, we had been working heavily, as I mentioned, with the National Institutes of Health, and they had a program called the Antimicrobial Resistance Leadership Group, and they provided us some funding to help develop this into a diagnostic. But every time we talked to the people who worked in the emergency rooms, the physicians who are actually wanting such a test, and most people want such a test that'll tell them, hey, this person is sick or they're going to become sick. We like that idea. But we need to know if they've got a bacterial infection as well. So it wasn't enough for them, and as we talked to them, to have just a bacterial infection or just a viral result. We needed a bacterial result as well. So luckily, we had been doing similar work in the emergency rooms, both in the United States, but also globally. And we had a broad collection of samples from individuals with different bacterial infections when they presented with pneumonia, etc. So we designed a study to help develop a bacterial signature as well and put that in place. And so we had a bacterial signature, a viral signature that we had initially developed in the challenge studies, and we had a non-infectious signature for those individuals who presented maybe with pulmonary embolus or a heart attack that had a similar presentation, but you couldn't tell clinically, did they have an infection or not? And just as an example of our performance in here, the probabilities, as I mentioned, are what are on the top rows, in this case, where they gather for the viral signatures, for the bacterial signature, for the non-infectious signatures. But just as an example, this is a 16-year-old adolescent with fever, cough, sore throat, and myalgias, classic flu. This was in 2009 during the H1N1 pandemic, and this individual had a viral probability of nearly 100%, and importantly, a bacterial probability of less than 1%. So in that situation, a clinician should feel pretty comfortable not giving antibiotics. So we're providing some support for that. Now we also there's probably hard to see these, but the general idea is we validated these same signatures in collections of data, of transcriptional data that were now on what's called the gene expression omnibus, or that is on the internet. And you can say that these individuals and these various studies had gene transcriptional data from either fungal infections or bacterial infections, non-infectious conditions, etc. And we looked at the performance of our study, and we used what's called the area under the curve. That's the AUC, and the higher or the closer that is to 1, the better the test is. So in this case, we have excellent performance in all of these existing data that are out there, giving added credence and support to the value of the test that we've been developing. We've also done this for COVID and demonstrated a similar viral signature, so it's picked up with our viral signature, but there's also a unique element of it that makes it look different than influenza. Everyone kind of realized that COVID was a unique beast in a lot of ways, and how it presented. You had that very high inflammatory response. You can see similar situations in influenza, but routinely that's one of the distinguishing elements, and it's helpful in that you can actually start with this technique. You can start looking at what the immunopathology is behind these different infections. That may help guide the development of new therapeutics or ways to intervene, the types of infections that may respond to JAK inhibitors or steroids, and those that may not or may get worse. So you don't only get the benefit of this probability that you're using as a diagnostic, but you're getting this background information of what's happening in the patient. But again, part of our charge from the NIH was to develop a diagnostic and move it through the different procedures and processes that are complex in the United States in particular for developing a new diagnostic. So you had to get these different mRNAs, and we had it down, somewhere between 20 and 50 RNA transcripts that we were going to be using and developing this signature with. We had to get those onto a platform that could generate data very quickly for us and give us an answer in enough time that it's useful to a clinician. And so that's what our charge was with this particular radical series of studies. And so what was it when it came time to actually put it on a diagnostic platform? This was our next charge, and I'm going to spend a few minutes talking about what was involved in that. So for a field or real point of care test, you want something that's really fast, and really, if anything's going to be practical in this part of the world where you may be seeing 20, 30, 40 patients at a time, you need a real quick answer. So where you're going to use this type of test makes a difference of what the requirements are going to be. But so it could be less than 5 minutes in that situation. Maybe it's less than 20 minutes in a U.S. outpatient situation. In our emergency rooms in the U.S., you're dealing, you got people waiting for an hour, they're sitting around, and it can take a long time. Once they're in the hospital, if things take several hours or even up to a day, there's still potential value for the test. So how rapid the test is needs to be depends on the use case you're considering. The complexity is important. You want it to be as simple as possible, particularly the closer to the patient that you're going to be implementing the test. It needs to be inexpensive. It needs to be very inexpensive if used here in places like Sri Lanka, but even in the US, it needs to be relatively inexpensive. It needs to be reasonably non-invasive. It needs to be a sample that's easy to obtain. Because of the number of targets I mentioned we're looking at, there has to be an ability to multiplex, meaning many different analytes that can all be accurately detected. And then ideally, you take a sample, you put it on the device, and you get an answer. So it's all integrated. So those are the characteristics of what we were trying to achieve. These are just some data that showed how we were trying to actually reduce the number of targets or demonstrate what the ideal or optimum number of targets would be. And we showed that better performance typically happened when you had many targets. The more targets, typically the better you were performing. But that it kind of flattened out once you got to the 20 to 25 range of targets. So that was our sweet spot for what we were going to be targeting. We worked with a company called BioFire. BioFire became very famous for using syndromic diagnostics, meaning someone presented with respiratory infection, someone presented with diarrhea, someone presented with encephalitis, and they would have a syndromic panel that has all the different targets, the pathogens on it, up to 20 to 30 of them. We use the same platform for our generation of a diagnostic test. And we demonstrated that we actually had excellent performance, as shown with our AUC here on the far in the yellow. That's a very high AUC of over 0.9. And you compare it in the red to a diagnostic many of you may be familiar with called procalcitonin, which is used for similar ideas, or CRP, I think most of you will be familiar with, as measures of inflammation may be more frequent with bacterial infections. But the performance of the transcriptional test is much, much greater than the performance of either procalcitonin or CRP when we used it on this type of a diagnostic. Now, we now have many different companies that are interested in this space. I'm going to speak to you specifically about the one that we're working most closely with, which is the one I had a relationship with which I mentioned, which is Biomeme. Biomeme is headquartered in the United States. It grew significantly during COVID because it had a COVID diagnostic that it made available. But they are known for taking a One Health approach to diagnosis, meaning they work on veterinary disease, human disease, as well as environmental contamination. The idea is that you have a molecular lab in your hand that they develop. And so these are some pictures of different environments where people are using the instruments that Biomeme has made available. So there's a continuum for the different types of instruments that have been developed over time. You can use their reagents on your own PCR machines. You can use their original Franklin device there in the middle, which you operate off of a cell phone, which you do extract the nucleic acids separately, and then you put them into the machine, and it does the thermocycling. It does this in under an hour, but it's about an hour. And then on the end is the integrated unit, and that's what we were developing for clinical purposes. And that's, you have a cartridge, you put the material, the direct blood into the cartridge, and all elements happen within that same device. And that, again, takes place over about an hour to an hour and 15 minutes. We were moving forward with this approach for that approval in the United States, and we had excellent performance for the distinguishing between bacterial and viral infections using samples we collected in a variety of studies preceding. And right at the time we were about to start that clinical study, the company stepped back and said, we're getting a lot of feedback that we're not fast enough now, because they're turning it around in about an hour. And so the company made a decision to not move forward with this particular platform. So the clinical trial that we were intending to do, probably the last time I was here and talking to you about it, never actually took place. But that doesn't stop things from moving forward. I'll talk about that in a minute. Here are just some comparative data for using that type of approach compared to CRP or a multi-protein panel or to procalcitonin. And we see that the mRNA example in blue has the higher AUC compared to that in green or the light purple, which is procalcitonin. So there's a substantial benefit, again, shown here in comparison with using this approach. So despite the fact that we weren't moving forward with that particular FDA trial, we were really excited about the technology still. So what were the future directions we were going to move in? Well, we wanted to see across different use cases, different populations, how this test would perform with different genetic backgrounds for people, because you're looking at transcription of the mRNA, so understanding when people have different DNA backgrounds, that may affect the transcriptional background. That was of interest. Also, the different types of infections that we may be encountering, and different clinical situations generally. Different sample types, saliva, respiratory samples, CSF are all of interest, urine. Different targets still being, we've looking at not only the mRNA, but protein targets. Also, we started to work with, and we worked closely with Drs. Himali and Da Silva here, looking at epigenetic changes in that can be measured when exposed to different pathogens, looking at methylation changes in the DNA, et But really, platform developments I'll talk about in a moment, and then just collections of big data and impacting that with better analysis techniques. So I mentioned that ISP platform, that integrated platform we were looking at. We did evaluate our pre-symptomatic data from those challenges and demonstrated excellent performance within a day or two, mirroring what we had done before with just very slow array-based approaches. We could actually generate similar results across all those different challenges with our handheld diagnostic device. So that was an exciting use case where we'd moved to a new diagnostic. We almost always get a question about how does this perform in immunosuppressed hosts. This is probably not as important here in Sri Lanka as it is in the United States, but as I mentioned, transplant populations are really important, but you probably have a number of patients on steroids, on azathioprine, on cyclosporin here. The question is, when you're impacting the immunological response. How does that impact the signatures that we're generating? Well, for the most part, it doesn't have much of an impact. There's a little bit of blunting for certain of the signatures. These are data from viral, bacterial, and non-infectious patients and demonstrates a slight reduction in performance, but for the most part, we're seeing a similar performance in our immunosuppressed populations. Then there's the question about what about the different types of infections that those populations get? And those individuals get a lot of candidemia, so Candida in the bloodstream, or they'll get a lot of invasive aspergillus or other fungal infections in the lungs. And so we've looked at those populations as well. These are some of the young investigators in our group looking at both of those questions and actually demonstrating that we developed a new yeast signature or Candida signature, as well as one for filamentous fungi. So just like we've done for viral infections, bacterial infections, these different types of fungal infections we can use similarly to aid in diagnosis. You can also look at how these signatures change over time. We did this naturally in the controlled human infection model studies where you gave the infection, you watched that gene expression over time, and it resolved after day 5 to 7, etc. Similarly, we see a response to therapy that takes place in people with fungal infections when you get them on an appropriate antifungal. So if you're using the test serially, meaning daily, you can see if they are having an appropriate response. If they're not having that response and they still have that ongoing infection, that's when you may want to change your approach and give a different drug, or you add on a different antifungal. Same goes with bacterial infections as well. If you're not seeing the appropriate response, maybe that's when you go to the carbapenem as opposed to using that as your first drug of choice, thereby trying to reduce that pressure on antimicrobial resistance. So again, I mentioned sample types. These are some data actually generated in collaboration with our colleagues down at Teaching Hospital Karapatia as well as Rahuna Medical Faculty. These are samples collected from the nasopharynx of individuals who were enrolled in a study looking at response in lower respiratory tract infections. And so rather than generating these expression data from the blood, we also generated it from the respiratory secretions. So looking at where there's been transudation of those factors happening in the respiratory tract and capturing that. And we see performance that's actually very similar with our AUC curves as shown in the middle as to what we were seeing with the blood-based signatures. It's very hard though. We need to work better at how we're stabilizing those samples when we're collecting them from the respiratory tree. That was using the signatures that we had already generated in blood. We actually then improved performance by developing signatures that were specific to the nucleic acids being elaborated in the respiratory tract. So this is a modification of that analysis where we get better improvement. We also took those data, and just like we did in those earlier studies in the emergency rooms, we had similar performance in data online in that gene expression omnibus, where we had excellent performance in those data collections as well with similar type patient populations. All right, I'm going to be finishing up here in just a minute. One of I think the areas that may be the greatest interest is for this group is how we are looking at what I call global infections, or particularly those infections that occur in the tropics, including here in Sri Lanka. We work across a number of sites in Kenya, Tanzania, in Central and South America as well. Again, I've got on the map here some of my original work in Nepal. And we developed a study with our Department of Defense support looking at performance of the signatures and improvement of the signatures, those blood-based signatures, across those different pathogens. Dengue, chikungunya, Burkholderia pseudomallii or melioidosis, leptospirosis, rickettsial infections. We had demonstrated that if you look at people presenting with fever, at least down in Gaul, between 15 and 20% had leptospirosis, and about 15 to 20% had different rickettsial infections, including scrub typhus. So these are not uncommon presentations, and we need better diagnostics for. So we were beginning to look to see how our test was performing. We used gold standard diagnostics, each looking at the best way to diagnose these types of infections, and many times having to rely on serology, acute serologies, secondary convalescent serologies to confirm infection. That takes a lot of time. That's not useful clinically, right? So we're trying to develop something that can use that immune response, but use it very early and quickly. And this is the distribution of those different infection types I mentioned, and we looked at also samples from the United States, a lot of common pathogens like Staph aureus, strep pneumo or pneumococcus, E. coli, Klebsiella, but also those leptospira, rickettsial infections, even Q fever, Coxiella infections, brucella, and then pseudomallii, as mentioned before, a variety of viruses, including dengue, etc., as well. And we demonstrated that across those different genetic backgrounds and across those different pathogens, we still were able to generate excellent performance using our bacterial and viral models of infection. Again, these are performance across those different clinical phenotypes, how our test was performing both for bacterial and viral infections. I want to mention leptospirosis in particular. It's been brought up just how important this infection is here, along with dengue and now chikungunya. We're in the midst of an outbreak here in Colombo in particular. But leptospirosis was brought up as part of the recent World Health Assembly. The Deputy Director General for Public Health Services in Sri Lanka, Dr. Arnold, helped sponsor a meeting about the One Health approaches to diagnostics last week. And he went on about the One Health approach that's necessary, that we need to do a better job using the technologies we have, but others also mentioned that we needed improvement in those diagnostics. And I think most practicing clinicians would agree we need better diagnostics specifically for leptospirosis. We've gotten a lot better using NS1 for dengue, but that's a classic problem or clinical situation, is that distinction between dengue and leptospirosis. We have a very large program from the NIH supporting host pathogen interaction and the development of new diagnostics for leptospirosis that help support a small study that we've done using samples collected here with our colleagues in Gaul, where we looked at a group with dengue and a group with leptospirosis. We know that clinical distinction, if you're just looking at the patient, is really hard to make that distinction. There are some laboratory differences. There are epidemiological differences. You know that if they're a rice farmer, they're more likely to have leptospirosis than not in those cases. But it's hard to, there's a lot of presumptions there, and there's a lot of improvement that we can make. So we took about 80 individuals who had confirmed illness. We generated data on that integrated diagnostic use. My colleague Jack Anderson helped generate these data. And actually this was on the external extraction device, But needless to say, it's pretty much the same types of data that are generated. And we looked at the performance of the bacterial and the viral signature in that particular use case and saw excellent performance again. So very exciting data that we generated on that particular type of situation that happens clinically. I'm going to skip ahead. There's a lot of interest in severity of illness and looking at predicting or prognostics who is going to go on and have more severe disease. One of the competing diagnostics on a platform called Inflammatics actually has that built into their diagnostic. We've worked with colleagues both here. Dr. De Silva has been interested in this particular question, as well as colleagues at Stanford, and these are data from their study. Excellent performance in predicting those who are going to go on and develop leaking or develop thrombocytopenia and potentially bleeding or more severe manifestations with dengue. And so you can think about combining a diagnostic dengue marker with a severity marker and the utility of keeping people out of the hospital and reducing overall healthcare costs in a place like Sri Lanka. Lastly, I've mentioned at the earlier on that we stopped that registration trial or that clinical study we were going to be doing in the United States on the bacterial versus viral diagnostic. We did that because we couldn't get a result back to the clinician fast enough. So we put a lot of energy at the company level into a new platform using new chemistry, which is called isothermal type chemistry, so not the heating and cooling that you do with polymerase chain reaction or PCR. This is isothermal. You don't heat it up. You just let the chemical reaction take place. Happens much, much faster. We verified that we can generate these same data and similar results using an isothermal handheld platform in under 5 minutes, or at least in 5 to under 10 minutes, potentially under 5 minutes, the speed with which we're able to generate this directly using blood from the patient and potentially using other sources as well. So the platforms are getting better. This approach is increasingly being validated. There is a world of different types of utilization that we can use the approach. It's not going to be used to the exclusion of the pathogen type diagnostics we've developed over time, but it's going to be complementary to them. It's an exciting world, and I hope these types of tools will become not only useful in the United States, where I'm developing them mostly for, but also for to help reduce the burgeoning antimicrobial resistance problem here in Sri Lanka and in similar environments. Okay, so that is my presentation. I'm happy to entertain questions. I realize I've taken up most of my hour, but I'm also happy to have conversation with you in the time afterward. Dr. Chari, what should I do here? Should I take questions or?
So I'm sure you have a lot of questions. Shall we see the students or? I
may have exhausted everyone because it's a long talk. 20 years of history.
That was quite interesting actually. I've been involved in a few projects myself as well. However, I'd like to give the chance to some of our students, and we have consultant microbiologists here as well, and then our professors also.
Sorry, I joined late. I'm Dr. Didini, a consultant microbiologist. So actually, I was not in your first 30 minutes. You must have explained that. So is there any way that we can check the abundance of these markers So yeah.
these are we do quantitative assessments.
Quantitative assessments, yes.
That's right. So these are when we're looking at selecting new platforms to use, the ability to be quantitative, or at least semi-quantitative, is really essential. You can't just have a qualitative cutoff for this type of an approach. So you really do need that ability to measure abundance and to have normalizing genes that work across different populations, so you can adjust your what those or inter-individual variability could be.
Yeah, what we observe is when we do a normal molecular assay, so we detect multiple organisms, right? So some may be like co-infections, bacterial, viral, both, and lot of organisms are getting detected.
So
in
this
that
is
case,
the co-infection question I didn't mention, but it's really important. And we have a lot of internal discussion about it. Number one, it's hard to adjudicate those clinical phenotypes, so it's hard to get a bunch of us, either infectious disease doctors or medical microbiologists, and have us agree on that's a co-infection case or that's a viral case, etc. That's difficult. We call that an alloy standard. It's really not a good gold standard, but there are a number of cases that do meet that co-infection case definition. And the approach we've taken is we'd like that the test actually says that you're going to get a result of one of four results. It's a bacterial infection, it's a viral infection, it's not infectious, or it's both. Because there's some cutoff in the probability that if it's above, it will end up in both. So that allows you to have a co-infection result, which is really going back, and you weren't probably here, one of the reasons we ended up developing the bacterial signature in the first place was because the clinicians really demanded that you can't just say it's a viral infection or that there's a viral infection not present. You have to say that for the bacterial infection, or that patient's still going to get the antibiotic. You're not going to be able to steer them away from it. So having both and the ability to say co-infection is really important.
Thank you.
So do we have questions from students? Because I like our students to also inculcate the culture of, continued medical education. Yes, please.
So I'm Uvinda, a fourth-year medical student. Considering the increasing role of the host-directed therapies in managing infectious diseases, how do you foresee the integration with existing antimicrobial strategies, especially with the resource-limited settings like us or any Asian continents? How do you foresee the possibilities?
Yeah, so you're speaking about antimicrobial stewardship programs, right? Because in addition to, we look at this as being complementary to those programs that have been developed, and these have gotten fairly mature in the United States and in Europe, but I think are really taking place here throughout South and Southeast Asia as well, and it's critical that those are in place, and most of those are changing behaviors. And the truth is, it's probably harder to change physician behavior than it is to develop a new diagnostic, right? It becomes really hard to move those practices that get inculcated in us, but we're getting there. And so strategies that restrict certain types of antibiotics or require that certain signs or symptoms are present before the provision of antibiotics, those need to take place as well. What we're trying to develop is an easy-to-use diagnostic that can be a bit of a crutch to the clinician, so that, yes, you're changing behavior, but we're helping them with a better diagnostic that says this is, for all intents and purposes, a viral infection, a bacterial infection, or you should be comfortable that this is a non-infectious situation. And it may push you in the direction of more diagnostic workup as well.
Thank you, sir.
Yeah.
So now we've discussed we have discussed viral infections, bacterial infections, co-infections. So I also have a little question. So this is like because I do come across patients with headache, and there are patients with chronic sinusitis. And then of course they do not have like a full-blown infection. So they have an occult infection. So how about the subclinical or this, hard to detect?
Well, that's a really interesting question. Do you have, for lower level infections that may be very focal, you really just need to generate the data, meaning you need to collect enough samples from enough individuals with those chronic type of infections. We're doing some work right now with recurrent otitis media, which will have some relatedness, and we've done the work with fungal infections, which we know that it works in bloodstream infections with Candida, in lung infections with the filamentous fungi. But let's say you have a mucor infection in a diabetic that's kind of chronic, and or an aspergillus infection that hasn't really taken off yet. Would this be a helpful approach in those situations, particularly when if you get the microbiology? Just because you can grow aspergillus out of a sinus doesn't mean that that's what's causing the infection, right? So if you can pair that with a host response that says this patient has a fungal response, you're going to feel much better about that type of infection, and you're going to be willing to give the long course of antifungals that's required. But we need more data in those specific circumstances.
Thank you.
Yeah. Okay. I'm happy to talk to folks privately too if they don't want to ask their questions in public.
So maybe we can have like 5 minutes after the session where they can personally talk to you. I'm sure you might be interested in doing research in US. So just like I think through CMEs we like to establish our network as well. So if anyone is interested in doing research related to immunology in US, so please we'll give you maybe 5 to 10 minutes after this so that you could personally talk to Chris, and so you can maybe do a PhD in US, right? But don't leave the country, right? I'm very patriotic. I want you to be in Sri Lanka, okay? Right.
You can do the work here, actually. We can
we can
help
collaborate
support
and
the
work. Yes, that's our strength, I think, because we have so many things in Sri Lanka, so we can collaborate and we get the best of both.
Work with Dr.
What I'm doing
Hamali.
here. Yeah. So yes.
Okay.
Okay. So then we'll conclude at that.
Thank you very much. It was a pleasure seeing everyone.
So I'd like to thank Professor Chris Woods from US for delivering that magnificent lecture, and also Chris, we'd like to have you on stage for a few more minutes, if that is okay, because we have a token of appreciation. So I believe that these are CME programs, so
One's coming out here.
So these are very small
Oh, lovely.
token.
What's even got my picture? Look at that. Lovely. Do I have a picture? Can you take? Thank you.
Thank you so much.
Thank you very much. Do I get to take the box?
Yes.
Thank you. That's lovely. Thank you.